but feel free to add or give more inputs or questions. Whatever we'll be able to answer, we can answer. You can drop them in the chat box, and my colleague Kamau will be taking them. Then we can answer them as we go by. So the question is, when you talk about syndromic testing, what is it? So in this case, you're saying syndromic testing is the probable kind of bringing together so many organisms or syndromes. So you bring them together and then try to diagnose all of them in one bit. So are we saying, does it bring new hope? Is it the new frontier? Is it the thing now coming in the market? Yeah, so that's quickly what we'll be looking and try to compare the conventional approach and the new approach which you are talking about. So you're welcome, and we can, I think, proceed. So the conventional method of diagnosis, when I talk about the conventional microbial diagnosis of pneumonia, in a normal circumstances, we do sputum culture. We can do urinary antigen tests, as you can see, and here we are targeting Streptococcus, probably Legionella. Other conventional way is through blood culture, serological investigations, and some other targets that maybe I did not put here. I mean, some other tests that I did not put here. But when you look at the etiology, based on this study that was done, only 53 to 75% of the samples, mostly pneumonia, mycoplasma pneumonia, and the Haemophilus influenza. So again, if you look in the aspect of outpatients and the wards, what are the target organisms? So here I try to get a study from Spain, and maybe in the next presentation I'll try and get local data. And you can see some representations from the ICU aspect, ward aspect, and an outpatient aspect. Like here you can see some mixed growth. You can see intracellular pathogens, streptococcus, and such like things. Or the bigger percentage is the unknown in either of the aspects. So that tells us there's something that probably are we missing, or maybe we're not doing it the right way, or something like that. Now, when you're talking about when you talk about the polymerase chain reaction, or that's the PCR, in a normal circumstance, we say it does not require viable bacteria, less influenced by antimicrobial therapy. Here, the reason why we're saying so, we are taking the nucleic acid material. So it may not be really based on the treatment, but yes, we are targeting the nucleic material. So whether the person has been on medication or therapy, that is to say, you can still target the viable bacteria in this case, or even the virus, if it's the causative agent of the pneumonia. If you look at the sputum PCR, yes, we say it is more sensitive method than sputum culture. That's a topic for another day, and especially in those previously treated with antibiotics. Yeah. And again, if you look at this study that was done by N. Johnson and et al., you can see when you're comparing blood culture, urine antigen, sputum culture, and sputum PCR approach, another method. You can see like with the sputum PCR, the sensitivity or the recovery was a bit high compared to the rest. Again, what are we trying to look in this case? Will help to tell the colonization from the infection, predict disease presentation and severity of the pneumonia serotyping. So all this is actually for the advantage of for the patient when you're talking about the syndromic approach. Now, again, I'll not go dwell so much on the data, but if you look at like what I'm presenting here in the case of a septic shock, you can see in terms of numbers and the septic shock, in terms of the percentage, you can see some of the complicated cases and uncomplicated case. Okay. Once again, when you're looking at acquired pneumonia, Sorry, can you hear me? Hello?
Yes, I can hear you.
Yes, you can hear you. Thank you.
Yeah, so when you look at, in such a case, for example, when you talk about an acquired pneumonia, you can see some of the target organism, patients with a positive result. When you talk about human rhinovirus, when you talk about influenza, pneumonia, some of the pathogens detected and other. So a pathogen was detected 38%, respiratory viruses, you can see the majority were 23%, no pathogen, you can see was 62%. So we are saying, are we missing something? Or rather, are you treating kind of a pneumonia that maybe could not have been the thing, or maybe you're attacking a certain bacteria, you administer antibiotics that maybe that was not supposed to be the target organism. So for a case of influenza, for example, we are saying rapid influenza diagnostics, RTDT, antigen immunoassay. So when you look at the sensitivity, again, this is based on the papers written, and if possible, I can be able to share these papers. The sensitivity is between 40 to 70%. Immunofluorescence antigen, again, sensitivity 50 to 85%. So you can actually admit or agree that the previous, compared to maybe the data that I've shared a while ago, there could be something that maybe we are missing. So in this case, you're saying, in comparison to PCR, high sensitivity and specificity, when you're doing PCR again, you can easily detect the influenza A subtypes. And in this case, we are saying, if you're only doing the other conventional methods, probably you can only identify one subtype, or again, in this case, you can only maybe identify a specific, maybe one subtype, so you need to redo another maybe test for you to detect the other subtypes or such like things. Again, individual subtypes using specific primers. Negative results may occur with nasopharyngeal samples, not provided information regarding infectiousness, and dead virus RNA fragments. Again, we know that for the people who understand molecular more, you understand when you talk about dead virus RNA fragments, yes, so you can be able to detect. But we'll be able to see in subsequent slides where you can say, when you're doing maybe the syndromic testing, you need to check with the clinical history, with maybe the presentation, the clinician should check on those so that you can compare with your syndromic testing. I mean, with your the syndromic approach. Again, now when we compare with multiplex, when you talk about the pneumonia, the multiplexing for PCR, some of the target organisms are influenza, RSV, human metapneumovirus, and you can see here again, when you're doing this, you can easily detect even some atypical bacteria. And in this case, we're talking of things to do with Mycoplasma pneumonia and also chlamydia, Chlamydophila pneumoniae, which in an ordinary case, we know for a specific lab to do that, you may need a very specialized lab procedures to detect. So when you're looking at molecular-based point of care tests, the target, some of them are available, but they're saying available for detecting influenza and other viruses at the bedside, the point of cares. What are we looking at? Is it viable? Is it of beneficial to the end patient? So again, we look at the accuracy comparable to the conventional laboratory PCR assays. So some of the multiplex equipments, or rather instruments that are available are, you can see from my picture here for syndromic testing, most of them do in less than 60 minutes. But again, what are we targeting? When you're saying broad coverage, are we only doing bacteria? Because when you're talking about pneumonia, in most cases, some people may only think of bacteria. But are we neglecting things to do with viruses? Are we neglecting fungal infections also? So when you're saying syndromic testing, we are actually covering broadly. We are covering bacteria, viruses, and in some aspect, the fungal infection also. And when we look at the difference, when we talk about with asyndromic targeting, without asyndromic targeting. So with syndromic targeting, of course, will increase the probability of identifying a pathogen using the right test, the fastest time possible. You can imagine when you're doing probably close to 34 targets, and of course, you may not get all of them together, but you can imagine when you're doing 34 targets, bacteria, fungal, viruses, and maybe some atypical bacteria, the benefits that you'll get after that. Then it eliminates guesswork and the cost of additional testing. You may be aware, for example, this is not a pneumonia case, but you may be aware of something like whooping cough, Bordetella parapertussis. Currently, we assume it was wiped off. But yes, when you go to some institutions using this syndromic testing, we've seen some reoccurrence of some Bordetella parapertussis and Bordetella pertussis. So that tells you some of these neglected targets, you can easily identify them using a syndromic approach. Then improves antibiotic stewardship. Some of these syndromic approach, like what we're discussing today, they also include resistant markers. So you may find, we know we have more than maybe 50 resistant markers or genes, but in this case, if you are targeting maybe the main, maybe we're talking about 7 or 10, and in this case, probably we're targeting things to do with the CTXM or extended spectrum beta-lactamase, or maybe we're talking about carbamazepine resistance, or carbamazepine, yes, when you talk about carbamazepine resistance, again, these are some of the things that you can easily target them within that 1 hour that we've talked about. So you can easily identify an organism and even go further and tell you if this patient was on medication, take note, he could be having a resistant gene. So another good example is maybe something like a Staph aureus. If maybe the patient has been on medication, on methicillin-based treatment, you can easily tell that this patient, as much as you've identified Staph aureus, watch out. The patient has a resistant gene targeting the Staph aureus, which could be MEC-A, MEC-C, or even MRJ. So that doctor or the physician attending to the patient, within that 1 hour, or maybe within that short period, you can easily tell, fine, apart from identifying, this patient also has some resistant genes, and you can now know the targeted therapy within that 1 hour. If it's a viral infection, then again, you don't need to administer maybe the antibiotic. So this provides a proper care management on admission and isolation or cohorting of the treatment therapy. So you can imagine, I'm assuming if it is within 1 hour, you can easily tell this patient needs antibiotic, or even goes further and tell you which approach of, or maybe which kind of antibiotic will be targeting or maybe administered to the patient. So without the syndromic testing, I can say, sorry to use the word, but it's an educated guess. The infectious causes remains unknown. So you'll use the commonly term that I like using, the bazooka way, where you just hit and whatever that you'll find that will be. But again, what if this patient does not respond, or maybe the target is a viral infection? So what are you looking at? Again, costs associated with additional testing. Yes. So you can imagine the wrong tests or no test may be ordered. So the costs associated. So currently we're working on something on a health economic approach using a syndromic approach, whereby we do a health economic approach and see if you're doing a syndromic approach compared to the conventional way, what is the health economic downstream to this patient or to the end user in terms of the patient's stay in hospital, the peace of mind, that maybe from the parents, the quick decision making from the doctor, and even the administering nurses or the caretakers. So yes, so when I talk about syndromic approach, we'll group probable organisms together and even go further and check on the resistant markers at the same time. So some of the target organisms, again, if you look, you'll see some of the organisms, for example, some of the target instruments, for example, in the market, when you talk about a film array, for example, for a pneumonia case, you can target easily close to 17 target organisms, that is for viruses, probably a 3 bacteria, depending on which panel you're running. If it's a respiratory panel, probably when you're targeting an upper respiratory tract infection, it could be more of the viruses than the bacteria. If you're targeting maybe lower respiratory tract infection, here you could be looking at more of the bacteria than the viruses, and also inclusive of some of the typical bacteria that I've already talked about, things to do with chlamydia and so on. So the other target equipments are Virigen, Extage RVP, eSensor RVP, depending on which instrument you probably prefer. But again, as you decide, look at the one that has maybe better sensitivity and specificity, and also time to results, and the approach. Which target organism are you looking at? Not just to identify blank, because we know others are nosocomial, so we need to be very specific on your needs, especially to the patient. Just to look at an epidemiological look, the concoction, or if you can say the comparison when you're doing a combined versus maybe the singleplex versus the multiplex. So on my right, you can see the color thing. You can identify so many organisms that maybe you could not have identified probably in the normal way. This is compared to a hospital inpatient and outpatient. So the colored here, sorry, you can see that they're represented by on the side here with some of the organisms. So we're talking about rhinovirus, maybe human metapneumovirus, and so on. So this is just a representation just to show you that you can, the kind of organism you can easily identify. And from an approach of this, you can even come up with an epidemiological tool that could be even be cloud-based or something like that, that can be able to tell you that for future planning, you can be able to know that during this time, or maybe in the month of March, you normally maybe experience a spike on RSV, or maybe a different kind of virus, or maybe a SARS-CoV-2 virus, for example. So it can be able to guide you on future planning from an epidemiological approach. So when you look at the clinical benefits, again, 75% you can see the multiplex. I think it's not widely used. For example, one study reported 75% of mycoplasma. Again, if need be, I can be able to share these studies of infections that are detected unexpectedly by the use of multiplex PCR. This is important because it is an treatable finding. Now, as I've said, currently, the challenge that is there probably, and if I can use for an example of maybe a panel like maybe GE, gastrointestinal, some of these target organisms could be normal in their own circumstances. So how do you approach in treatment, in treating also? So again, there are algorithms that are developed that can be able to aid in knowing if this is a treatable organism or it's just a nosocomial infection or maybe something like that. So all those algorithms are available. Again, maybe in the next discussion, we can be able to discuss more on them, and maybe if need be, we can be able to share. Again, if you look at probably each year, more than 10,000 courses of antibiotics are prescribed for viral conditions. So we are saying from my previous presentation in the introduction, I was saying, is there something that we are missing? Most of us we've seen could be having a patient going to the ward, admitted, but you're not sure what you're dealing with. Put on antibiotics, 2-3 days, still no response, only to come maybe and realize probably it was just a viral infection. Or maybe the target antibiotic the antibiotic that was given is not targeting that organism based on what you found. Yeah, maybe the organism you're targeting, the cytoplasm, and probably these are different kind of bacteria in this case. Okay, so again, if you look at the routine use of molecular point of care testing for respiratory viruses, it did not reduce the proportion of patients treated with antibiotics, yes. But again, how do we push this and tell and spread the gospel and tell them that the syndromic approach is the way to go now, whereby you can be able to tell and know this is not a viral infection. You do not probably need an admission, maybe to wait for a culture report as much as still the gold standard. Yeah, so there are many questions there still to be answered. However, more patients in the in this case, or that use the point of care, you can say probably received single doses or brief courses of antibiotic, because in this case, probably you started the treatment, then all of a sudden, probably the report comes and says it's not a bacterial infection. What happens? So there are chances that the medication will be dropped. Then what next? So that's where we are coming with things to do with the resistance and so on. So when we're saying a syndromic approach, again, some of the advantages is the potential to de-escalate antibiotics if a viral pathogen is detected. So again, if it's a case of admission, maybe you're suspecting a bacterial infection, or maybe it's suspecting a pneumonia, but you're not sure if it is bacterial infection or a viral infection. But in this case, we're saying if you're sure and doing the targeted therapy, you can easily, or maybe the patient is already on medication. You can, doing a syndromic approach, you can be able to tell, now I need to de-escalate or escalate the kind of medication that the patient is at that current time. So that's what I'm saying. You can either de-escalate or decrease the use of invasive sample collection procedures to know which specific target are you looking at. Also, it will allow informed decision to be made regarding infection control measures and timely outbreak investigations. As I've said, most of them, they have an epidemiological tool that could be cloud-based or still the conventional way, whereby you can be able to know, like for example, in Kenya, during the month of probably around June, where we experience the cold season, you can maybe see a spike on RSV and know, yes, during this month, and take appropriate measures so that you can control it. Unfortunately, some of the disadvantages, again, it may not allow the customized ordering. Some of them, they come with already like a programmed primers and softwares. So it's still work in progress. Some of them are still improving so that you can be able maybe to customize. Unfortunately, again, still, most of them are still expensive. So you can imagine when you're grouping close to 20 organisms, developing primers for the specific and putting them in one concoction, yes, it could be still not affordable. But I know with time, things will be coming, maybe the cost will be becoming lower. But yes, we still acknowledge they are still a little bit unaffordable for low-class people, sorry to use that, for a certain kind of people. Okay. Again, on the other note, positive result may not distinguish between colonization and active infection. So when you're using a syndromic approach, it's very important that the service provider should be able to provide maybe like an interpretation algorithm or tool on how this can be helped in interpreting the kind of report that has been generated. Then when you look at the laboratory results, should be interpreted in context of clinical findings. For example, if the patient maybe has been traveling, or maybe has been in cold season, or maybe it's a how can I say, maybe it's a historical issue, or maybe a family genetic something. So as much as you have these reports on the report, and maybe so many organisms that have been identified, still it's advisable you interpret the report based on the clinical findings. Now, again, I've already discussed this, but when you look at some of the advantages, for example, I'll just put this screen here for you to see. You can see this, like I picked this one from a film array. It just shows you some of the peaks or the syndromic trends for film array. I'm just showing you how the trends are going. Like for 2010, 2011, 2012, I couldn't get the latest one, but you can see how the trends are all going, and you can even narrow down and get to see, sorry for that, you can be able to see if it's all caused by pneumonia or which kind of organism, and you can easily see which month has a peak, for example, in this case. So it will even narrow you down and say, specific organism maybe during this month, and you can be able to prepare well in advance. So this will be able to answer your question probably, will I manage my patient differently based on the results of this test, e.g., what if I get a positive? Again, is a targeted testing, e.g. influenza, due to maybe the clinical presentation, or it's because of our seasonality or something like that. So we need to be very specific on that. Again, when you're talking about the distribution, you can easily be able to know, is it maybe a widespread problem, or maybe a local, how can I put it, like a local problem. Like for this case, when you're targeting something like talking about escape, you can be able to know which region, where is it best, and maybe have a better approach towards managing it. Some of the hospital-acquired pneumonia, again, you can see some of the distribution. Unfortunately, maybe we may not have enough time to discuss on this, but maybe if you need, I'll be able to share this slide, so maybe you can be able to have a more visibility on the same. For this case, I just wanted to show you some of the resistant markers or maybe organism, and some of the shared data that I was able to get, for example, for carbamazepine resistant, for Acinetobacter, and like, for example, Escherichia and Enterobacteriaceae. And you can see how the flow is going. Unfortunately, again, I'll apologize, I don't have the recent data, but in my next presentation, I'll try and get the most recent data. Okay, so most frequent multi-drug resistant bacteria involved in pneumonia are MRSA, and we've already said how would you be able to target such. And in this case, you're talking about, for example, something like Pseudomonas aeruginosa, Acinetobacter. We've already looked. If you see here in my slide, Acinetobacter is one of the carbamazepine resistant. And in most cases, you may find it maybe from patients who have been admitted or inpatient clients. Then again, when you look at reference diagnostic techniques, yes, most commonly the gram stain or the conventional way. You do a gram stain, probably a culture. If you have a multitoph, yes, you can do, and then proceed to susceptibility. Now, what are some of the disadvantages, or what are the challenges, we can say, when you're doing such procedures? So difficulty in differentiate between colonization and infection. Requires a minimum of probably 2 days. Low sensitivity if the sample is taken after the start of antibiotic. So those are some of the challenge which we could be looking at, and I put maybe a diagram just to show a summary on the same. So we could be looking at a multiplex PCR or MPCR exome analysis. You'll see in my subsequent slide where like you blow, and a rapid chromogenic test. Now, when you look at maybe, for example, in this case, for this organism, when you look at maybe fluorescent in it, how do you call it, sensitivity, based on the fluorescent in situ hybridization, you can see the sensitivity is up to 100%, and specificity of up to 97%. Antibiotic susceptibility testing in less than 12 hours. Now, if you look at multiplexing, you can simultaneously identify and quantify the multiple respiratory organisms. I have said most of them are 23, 34 target organism. You identify within 1 hour or less, or maybe 2 hours, depending on your tool which you're using. You can easily also, from the same sample, detect the drug-resistant genes in about 6 hours. I know some even do within 1 hour. And most of them target only the specific or only the important drug-resistant genes. For example, if you're looking at maybe Pulmonary, I know they could do up to 10 of them. And if you're doing blood, and if you're doing maybe sputum is up to 7. And most of them are carbamazepine, ESBLs, and so on. Okay. So this, I may not dwell so much on this because these are other, I was trying to put some of the other equipment. Like for example, Unvero, multiplex PCR, the results were obtained on an average of 6.5 hours. Yeah. And you can easily, and the sensitivity is at 89, or I can say 89.2%, and the specificity of 97.1. Discordancy was also concerning level, probably because of the detection of resistant or related genes from the resident specific of airways. Again, these are papers I can be able to share. Test failure in about 40% of the samples, again. So these are diagrammatic approach of this tool on how you can be able to do. So real-time breath analysis. So you breathe, then using a mass spectrophotometry, you can be able to detect quickly and within a specific time, and give you an analysis of the target organism probably that have been identified. And you can be able to know the breath ion intensity in terms of counts within this breath, depending on the timing of what you have done. Again, the same thing, just like from how can I say, like a high perspective. So you can be able to get even the peaks and maybe know the specific organisms. These are just, again, another representation of depending on what you are looking at. So you can do from the nose and so on, and now compare the sensitivities and the specificity. Again, not quite important for now, but just to show you some of the comparisons that have been done. Some of the rapid detections when you're doing maybe things to do with the ESBLs, so you can do or carbamazepine, but look at the sensitivity again, 80 to 95%, and the specificity 71 to 100%, depending on what you're looking at. And again, look at the organism. What are you targeting? If there are no antibiotics, we are using maybe some of the antibiotics and the target organisms. So again, look at what you're targeting, and at the end of the day, you can always determine. So again, another diagrammatic representation of if you're doing a multitoph versus maybe a mass spectrophotometry or maybe one of the tools, for example, biofire and the culture. So look at the recovery in terms of time. So you can see the culture, which is still a gold standard, and we are not disputing it, but look at by the time you get like all the reports and so on. But then compare with things to do with biofire or mass spectrophotometry or other kind of diagnostic tools in a syndromic approach. So an example of the presentation, an example of a pneumonia panel, for example, if you're looking at a BioFire, for example, it has 35 targets. And out of these 35 targets, look, this one maybe now you're targeting lower respiratory tract infection, where we are looking at more of the bacteria. Again, for example, for BioFire, it will give you a semi-quantitative approach, whereby it will give you the quantified value of these bacteria. You'll have some of your typical bacteria, Legionella, Mycoplasma, and Chlamydia. As I said earlier, some of these organisms, unless you work in a very specialized lab, it's when you can be able to detect such organisms. And look at the viruses. Yeah, so you'll do influenza A, B, and you can even have up to subtypes at some extent. You can also check your coronaviruses. And again, for coronaviruses, you can be able to know probably, are they the HKU1 or so, or something like that. So you can be able even to narrow down to the specific coronaviruses. And again, something to do with maybe mass coronavirus, that the Middle East respiratory coronaviruses. So you're able to know probably, is it a patient who has been traveling, probably crisscrossing different countries. So doing this, comparing with the clinical approach, you can easily now narrow down on targets and know, yes, this is the causative agent of maybe this infection. Again, look at the antimicrobial resistance. As I said, for these, I know they're doing, I think, close to 7, 1, 2, 3, 4. Yes, they're doing close to 7. So from the word go, you can be able to quickly tell, for example, if it is maybe number 1, MAC-A, MAC-C, and MRJ, you can quickly know these are Staph aureus. So together with targeting all these organisms, and maybe it shows a positive for Staph aureus, you can quickly know, again, if it's a MAC-A or MAC-C or MRJ. If it is maybe another organism, you can quickly detect using, tell within the antimicrobial resistant genes range that are available. Of importance, again, some of them have started including some fungal. Again, like for this case, you can be able to tell Cryptococcus species. Now, depending, again, with the tool, you can even narrow down whether it is Gati or Neoformal or so on. So you can easily tell which kind of target organism are there. So as I come towards the end, if you look at the pros and cons, yes, the pros are convenience, rapid turnaround time to results, guide treatment, as I've said, that targeted therapy within 1 hour, for example, impact on isolation of the practices, patient satisfaction. The patient comes, and within that short period, you're able to tell the patient, yes, this is what you're targeting, and this is the next step of approach in terms of your therapy. And also for future developments, epidemiological studies. As I've said, we have some of them have the cloud-based tool that you can be able to pull data from different locations or even within your institution and know and come up with a future plan in terms of planning. Unfortunately, yes, every tool, every advancement has some cons. So in this case, some of them are a bit costly, not tailored to individual patients, nucleic acid detection, viable organism. So maybe this could be, sorry, dead organism, but still detected. Are they still viable? So that will say you really need to compare with their clinical approach again. You could be detecting asymptomatic carriers, prolonged shedding. Yeah, does it make sense? For hospital or maybe for healthcare providers, you know, we normally shed normal pneumonia, how do you call it, aerosols. So could that be maybe also some of the, so it really needs to compare with your clinical approach from the doctor also. May still need culture, additional PCR, antigen, just to rule out, just in case you're in doubt. Potential for contamination and false positive results. So it needs a lot of pre-analytic. Well, how are you handling that sample before you handle it? Because, you know, for a PCR, most of them are PCR based. So if you mess even a little bit, then be assured you will detect something. So your pre-analytic also matters a lot. So again, as I said, another advantage could be some of them are less than 60 minutes. Some could be more. So depending. And you can see the probable targets could be more than 20, or depending on the service provider. So again, the advantage, one of the good news is some of these promising techniques are becoming available, and the costs finally could be coming down, or the candidates for the drug-resistant microorganism detection tools could be more available again. And I come to the end of my presentation. Maybe thank you for your attention, and maybe I will open the floor for questions. I can see some inbox come out.
Yeah, thank you very much. Excellent delivery. We really appreciate you for taking time to share with us this very innovative technology in the area of multiplex PCR. We're really happy and thank you. We also hope that you'll be able to share with us the materials that you just presented. The co-host today was supposed to be Mr. Wakungui Wasakwa from Masinde University. Unfortunately, he was traveling in Pretoria. I don't know whether he's back. He's going to say a few words. But then very quickly, we can see our colleagues from Rwanda, led by Mr. Aniseth Rukongoza. Is actually on board and wanted to ask a question. So I'd open it up for you, Mr. Aniseth, ask your question, and then the rest can follow. And thank you, Rwanda, for joining, Uganda as well, Ethiopia and Tanzania, and of course the local team here. So Aniseth, do you want to go first, or we give somebody else a chance? You could unmute and speak. Okay, any other person with a quick question? We have 6 minutes. Anyone with a question? So maybe I will just pop a question to Mr. Edwin Masese. Do we have this technology in Rwanda as yet?
I may need to check with my colleagues there, but there's, I'm happy to share that East Africa is one of the sharing regions. Yeah, but again, if you need more information on the same, maybe we can be able to discuss.
How about Uganda? I see quite a sizable crowd from Uganda. Would they have this technology available?
Yes, in Uganda we have. I'm happy to share and say maybe one of the institutions like the IDI, Institute of Disease Infectious Disease Institute in Mulago. I know they're doing a lot of multiplexing, syndromic approach. Nakasero Hospital, I know they started using a syndromic approach to diagnosis of diseases. I'm sure some of the other institutions which could be joining soon could be IHK and so on here. So, and also, sorry to, I've forgotten, Mbarara University in Mbarara. Yes, they're doing a lot of CSFs on using the syndromic approach. And in this, actually, IDI in Uganda, they're doing a lot of pneumonia cases. I mean, pneumonia studies using a syndromic approach. And here we're talking about Professor Orodria. So if you can get hold of Dr. Orodria, Professor Orodria, sorry, yes, he's doing a lot with a syndromic approach with pneumonia cases.
A quick question from Lira University Hospital in Uganda. The question is, does this platform work and is it compatible with Link's web-based data collection tool? Mr. Jacob Ogule would like you to answer that question on the compatibility with the Link's web-based data collection tool.
I may need to check maybe and come back, but I know we have our cloud-based tool that I'm very sure could be, because most of these organisms, if I can, most of these tools, if I can say, especially the BioFire, they're normally FDSC approved. So which could be, I'm almost sure it's connected to the LIMS and to the other online nets.
Okay, thank you for that. At this point, I wish to invite our co-host, Mr. Wakungu Wasakwa, Senior Principal Technologist, to wrap up this for us. Please proceed, Mr. Wakungu Osakwa. Okay, Mr. Nyehangan, you could go first, and then we allow Mr. Sakwa to close this session. Thank you.
Thank you
Mr.
very
D.
much.
Nyengan, thank you.
Thank you. Thank you very much, Edwin, for the nice talk. I just wanted to find out what the basis for deciding which organisms to include in this point of care test was. Was it based on the epidemiology of the region, or it was something that was decided in Europe and we're actually looking for all sorts of things that don't even exist here? Or do you have some literature about the pathogens we would expect in respiratory specimens for this kind of multiplexing in the region? Thank you very much.
So if I can answer you, and probably you know, one of your institutions, one of the institutions that was used to validate the upcoming panels, but before the instrument or before the technologies roll out to the market or to the clinics and research institutions, it's normally done a market evaluation plan, whereby organism may be targeting this region, they're normally input. I know one of the questions raising is Europe and Africa, for example, these are different geographical representations. And if you're looking at that, does it cover our, maybe, for example, in Africa or maybe East Africa, does it cover maybe organisms that are targeted as tropical in our region, for example, as compared to maybe Europe? So the answer, I would say yes. Normally, these instruments are normally spread out, and target organisms are normally put and maybe prepared based on regional representation. As we speak, for example, currently we have a fever panel that is being validated, and some of the equipments were put in Kenya, Uganda, I think Tanzania, and so on. So the representation is normally cuts across the globe. I don't know if I've answered your question, but I can be able to share with you some of the data that is normally used to come up with the panel. I don't know if this answers your question.
Yeah, absolutely. I'll appreciate the data. Thank you very much, Edwin.
Okay, you're most welcome.
Thank you.
Yes.
Maybe Mr. Kamau.
We only
Mr.
have
Kamau?
1 minute. We have a new meeting starting immediately, so we have to give them a chance. We're going to make a hard stop, but before that, let's just allow Mr. Sakwa to make his closing remarks, please.
Thank you very much. Sorry for that. We appreciate what MedSkill Africa is doing. We'll keep on keeping on. I was supposed to moderate today, but because of travel business, I could not be able to. We promise to do better next time. And Edwin, thank you very much. Colleagues, I want to encourage you to keep on keeping on. Technology is here with us. We cannot run away from it. And the term cost is relative. We have seen the whole world, mission hospitals, public hospitals, running PCR for COVID. It's just about how we package it. So let's keep on keeping on. Thank you very much. And can we allow the next meeting to take off? Bye-bye.
Bye-bye, and thank you very much.
Thank you. Thank you, guys. If you have a topic of interest or you'd like to support with the next session, maybe make a presentation, there is an email address that is sent to everyone on a regional healthcare initiative. Please send them an email and they will be glad to schedule any other talk. This talk can actually be executed either from Rwanda, Uganda, Tanzania, the entire East Africa. I can see my colleagues from Malawi, Zambia, and Zimbabwe have just joined. So feel free, wherever you are, to use the email that I've posted on, I think somebody has posted it, yeah, Regional Healthcare Initiative. Send them a message, let them know that you have a topical area you'd wish to share. We know most of you are running quite a number of research work in your respective countries. Feel free to share with your colleagues. You know, the doctors have taken advantage, collecting data and sharing on our behalf. Now you have an opportunity to do it. And this is with a lot of respect to the doctors on the call, just to empower the laboratorians to also share data, especially that which they've collected within the lab. From me and the rest of the team is to say thank you and see you next week, where we will be looking into procalcitonin and one other area of laboratory superintendents. Should they continue working within the lab, going without being noticed or even remunerated? That would be a question to be